treatment effect heterogeneity, right? A systematic way to get at it. We've seen already papers today. I mean, some of the best work on the impact of IT, of course, is about not what the mean is, but how you might target it and how heterogeneous those impacts are. That's a really powerful area where there's a lot of new work that brings sort of causal inference, but data-driven methods to assess kind of what X's actually are impacting Y. What are the conditional treatment effects? Again, it's to this point of that's no longer sort of a faux pas to data mine, but we have to think systematically about it. And secondly is the ability to actually implement and deploy very large-scale field experiments. So there are engineers in the room. Usually I'm talking to economists and I'm saying, well, engineers do this. But in this case, you actually know. But I think there is a movement towards not just saying, okay, I've estimated beta 1 in a regression, but actually the ability to have a more complete solution. That is to say, I've estimated some treatment effect. Now I'm going to do rapid experimentation, potentially to test whether or not that actually impacts behavior, and then refine that. And ultimately, if you're a researcher, that actually is going to be an all-encompassing paper. And partly that's driven by a lot of economists who are now sitting, bridging the divides, particularly between technology firms and academia. So if you look at Susan Athey at Microsoft, Hal Varian at Google, Pat Beyer at Amazon, right? There's the ability to basically say, actually, I'm going to think about causal inference, and I'm going to think about what's going to happen when I, change a price or change a screen you see. But then I'm going to refine that, potentially using sort of an underlying structural model of behavior or something like that, and then test that very quickly. My observation is that we are poised to be able to do that in the healthcare sector. It's somewhat more fraught. I'm certainly less concerned if I guide someone to a slightly different book than if I change a physician's treatment decision. But in a lot of cases, a priori, we don't know which one's better, and there's really will be an opportunity to actually test these directly. Okay, so I think that's a motivation. And to be clear, I'm going to have to fly through some slides since the time is adjusting around. So my outline, which I will get to some share of, and I'm actually going to go a little bit quickly over kind of what are big data methods, because I feel confident that I will appease nobody. But I'm gonna give you sort of a grab bag and have, so some of you in here, right, are gonna say, I'm in information systems, I'm a computer scientist, this is like super, I learned this a really long time ago. Some economists are gonna say, well, I was told that this is absolutely what I shouldn't be doing, and I might have heard the names. But I do want to just sort of give a motivation for the different features and move forward a little bit quickly. And then dive into, I think, an interesting application and sort of a big policy question where there's lots of places where we might get traction, but where this actually has something to say. And that's a sort of fundamental decision. It's not, it may or may not be a competing decision, but do I think that supply side or demand side tools are actually going to be a more effective way to get people to consume healthcare more efficiently? That's higher value care. Okay, so a lot of talk about big data. Let me just very quickly, and I think Jeff Sintro really got at this, which is, it has been viewed mostly in the media as the domain of, ironically, actually, the domain of computer science. Really, it's the sort of the domain originally of statistics and biostatistics. But, a lot of it has been about how much data do we have? Can we store it? Can we set up a nice MapReduce setup so that we can estimate something on it, right? Like Google needs to take a mean and they need a massive infrastructure to do that. That's sort of been the view of big data, or sort of what it is. And on the other hand, you had economists saying, well, I'm not sure, implicitly saying it's beneath me, or I only worry about causation. And I think some really move forward, you have to bring those two together. And it depends on the application, absolutely. And I think there are, I think this certainly as you get more and more empirical applications, a one-size-fits-all assessment of what good empirical work is or what big data is going to be even more obsolete. But you do see this. And as I mentioned, right, a lot of the big technology companies now have chief economists. And frankly, actually, a lot of the applications of data methods flow through those offices, even though, of course, the collection and gathering of the data and the systems to do it typically comes from engineering. What I think of data science is a very sort of amorphous term. It's increasingly used. I actually think of data science as combining these two properly. There's a lot of data science programs that probably don't agree, but I'm going to motivate you that as we as a room who are seeking to understand more complex healthcare questions and understand both how they might be, why they might exist, and how we might change them with IC solutions, we should be thinking about this data science as kind of the metric to at least think about. So what is big? I'm going to be pretty quick here. It can be wide or tall. That's simple. Just think of spreadsheet. Wide data, if I have P observables, it's just really, the extreme version of this, and this is why a lot of these methods were originally built, right, is I have a genomic study of 50 people, of 10 people, of 2 people, right? It's extremely wide, but almost no observations. It can be large, right? We have a lot of observations, and we're used to that. Or it can have both. But I would motivate that, ultimately it's still about finding where the variation is in the data, right? Why are we seeing what we're seeing? And I want to give you an example shortly, but I think just because they're big doesn't mean it's useful. I'm probably preaching to the converted on that to some degree. But let me give you a little example, and this is a nice piece by David Laser and co-authors in Science, looking at Google flu trends. And some of you may be familiar with this, but there's Google flu trends, right, is often trotted out as, it's really exciting, technology is going to solve all these health problems. We can predict this using kind of the metadata from other settings. And what's been observed, that you can see, maybe you can see, my head's in the way, basically the fit and performance in predicting basically flu prevalence based on search behavior has in recent years continued to perform very poorly, over-predicting by more than double, right? And for example, in 2012 and 13, they predicted high 100 out of 108 weeks that they did this. So this is concerning. So what might we, we as researchers who think about empirical questions and causal inference and other issues, deal with this or think about sort of, are there things to learn from this? And one observation is that this is actually wide data, right? At the end of the day, I've got a lot of X's in some sense, right? I see all these different locations and people are searching flu or not. But all I have to fit is the CDC flu prevalence data, right? So I only see different markets. And that's actually the only variation there is. And I certainly might think there could be temporal autocorrelation there, right? Different search patterns across different locations are going to be correlated over time. There's going to be seasonal differences and errors. The kinds of things that we all think about when saying, well, actually, how many hospitals do I see in the data? If I just estimate if I don't cluster my standard errors, if I cluster at the patient level, not the hospital level, I'm going to get really different results, right? Interestingly, other features that I want to motivate you in thinking about is actually algorithmic dynamics. So it's simple after the fact, but they changed the autofill. That's going to affect things, right? If you type FL and it always leaves you with U afterwards, you're going to get a lot more flu searches independent of whether the person has the flu. Now, hopefully you're not sick. Why am I telling you this? It's actually really important if we think about studying what I think is a really great an exciting new area for economists and health policy research, which is micro clickstream data and detailed data coming out of these IT and EMR systems. Well, we need to be very careful about sort of ad hoc changes to the algorithms, ad hoc changes to what's going on under the hood, right? That means that as researchers, where typically, we might go in and say, I've got a big data set and I kind of know what's going on. As you get more granular data and data sources and experiments, it also means that you're going to need to be more careful about at a more granular level what's happening. And then the last one, which I think is interesting, they call this red team attacks in this paper and other settings. That's basically where the existence of the algorithm or the existence of the study actually changes behavior. Now, in this case, that's not hugely a huge issue, but I think I motivate it here because we as researchers are studying questions that exist in a marketplace, right? They don't exist sort of by themselves. And so I was just at Brookings a few days ago, giving a paper on using basically large-scale data to help people make better decisions about health insurance and actually think about whether we can do sort of so-called smart defaults, right? I'm not just going to do nudges ad hoc and move the celery forward for everybody. I'm going to actually be able to say, well, Jeff, given everything I know about you, actually I can do a default, which is ex ante going to be the best option for you. Now, of course, you have the freedom to make a decision to move elsewhere. When you start thinking about using the kinds of methods that we're developing and estimates we might have for, say, choice errors or utility, you then have to worry about how the actual marketplace is going to respond to that, right? So if you're perfectly right, it's fine, right? They're adjusting what plans they're offering to respond to the algorithm. But I think that's just another feature. And again, this gets to this broader theme, which I want to bring up, which is as researchers, we are in a excellent position to not just say, okay, well, I estimated beta 1, it matters. But actually to take it to the next step, to go into partner hospitals, partner setting, and say, actually, can we do an experiment to change this? That does change the game, and you do worry, to some degree anyway, about these kinds of algorithmic dynamics. And so the key takeaway from this paper, which, by the way, it's like 2 pages long, it's a nice paper, it's good for students, et cetera, but they basically call for the so-called all-data revolution, and I think that's sort of where we want to think about as empirical researchers and people in this setting, to actually think about that as a goal. So I'm gonna jump over some of this quickly to think about, these are sort of the different approaches. Actually, let me go through these quickly and then I'll go, just making sure the clock kept ticking. I'll go through these and then just jump over a couple slides shortly. But so if we think about the standard linear models, which you might estimate, right? We've seen a lot of it. We have a lot of, good tools for as econometricians to deal with these linear models, right? We typically think of an OLS. What's the first toe in the water of sort of big data, machine learning, data mining, whatever you want to call it? And again, a lot of this is nomenclature, so this is not wildly new in some sense. But I think it's pretty powerful and it's getting more and more accepted. It's just simple penalized regression models. For those of you who are not familiar with that, think of it simply as adding in a penalty to your OLS regression, where the higher the estimates, the higher the betas on all of your terms go, the more you have to basically pay a penalty on that, right? So your criterion function is changing, where basically you're maximizing something where it's costly to assign a non-zero weight to any of your independent variables. Now, what does that do? Basically, as you crank up the penalty, it's going to flexibly look at the X variables that you have that best explain or best minimize, right, sum of squared errors, right? Same thing we've always been maximizing, but that's going to allow you to flexibly understand what's in your data. And I bring this up not because you necessarily want to run this regression, as your main, table 1 or table whatever, you have to have their means, table 2. But in fact, I've often used this, and a number of colleagues use this, just to say, I got all this data in. Does it make sense? What explains things? What might I be focusing on? It can be very powerful, even just as a simple data organization tool. But it's also powerful, and I'll show you an example, in flexibly looking for kind of the most important factors in certain features. We then move into so-called, basically nonlinear models, tree models. I'm not going to dwell on it, but that's actually a powerful option in thinking about, in relaxing the linearity assumption, in flexibly understanding the impacts of different components and high dimensional representations of interactions. And that can be very powerful in healthcare, right? If you think about saying, well, I want to think about the health state of someone and how that impacts their outcomes, well, I might want to say, what are the drugs are they on, right? That can be pretty predictive of health state, but it's certainly going to be more predictive if you have a nonlinear interaction, right? The fact that you're on Lipitor does not tell me a whole ton, besides you're an American male over 50 or something. It's also a first approximation. But the interaction of that with something else might actually be very powerful, and so you're going to be able to get a lot further with those kinds of models. Similarly, you're going to be able to actually deal with higher order moments or more heterogeneity, which is, again, I think a key motivator. And then clustering models, which, again, are not wildly new. In fact, in some sense, there's some sort of old school features of this, but actually unsupervised learning to just say, can I partition the data in a flexible way, can be powerful. So, I'll leave it there and jump over a few of these here to sort of motivate different features and different methods. And I'm happy to provide sites. Many people will know this, and there's other sites out there. Probably the best introduction for those of you who are economists is Hal Varian has a piece in the Journal of Economic Perspectives, Big Data, New Tricks for Econometrics. So the key question in all of this is the trade-off between flexibility and interpretability. And I think that's really where a challenge faces us as economists, both in terms of what we're doing, but also in terms of, a reviewer saying, what the hell is this? I wanted to see if, demand sloped up or down, and you've just told me that you're predicting people's purchases, but I have no idea why, right? And that I don't have an answer to that, but I mean, I think that's really going to be a challenge to think about going forward. It's a fundamental issue in healthcare more generally, and I bring that up here because we as researchers want to think about that. There's often a different constraint put on the kinds of tools we might build, which is it needs to be clinically interpretable, right? A clinician wants to see that the beta on sun exposure was high for people with skin cancer. That's a little bit simplified. Yet that can be a very important constraint on how predictive these models can be. And I don't have an answer for that, but I think it's something that actually is a fruitful area for research as we go out and actually want to use IT systems, want to use measures to say measure quality. It's a great example for quality measurement. Right? I want to do a risk-adjusted quality indicator. I'm going to do worse risk adjustment if they are all clinically explicable. Yet, I might not get buy-in from the doctor. And that's a behavioral component combined with a statistical component that is going to be absolutely fundamental going forward. And this is an old letter. You probably can't see it. It's like way down. The Cabbage report cards, all of the letters written are available online. They make for some interesting reading, but you see sort of this evolution of eventual acceptance. But you see a continuous stream of these letters which basically say, our investigation demonstrates that our level of severity index is greater than reflected in this study. No explanation why precisely, but I think that's going to continue to be an issue, and it's going to be particularly an issue as we get into more complex types of models. I also mentioned, for example, that the ACG software for predicting, say, outcomes off of claims, that's a constraint that really binds there, right? You can get out of sample predictive performance with claims-based black box machine learners that we've built that's 2 to 3 times higher than the ACG software. Yet if you look, they've explicitly said, we want clinical interpretability and clinical models underlying it. So that's a motivation or a motivating question as we move into using more and more of these tools in a clinical setting and a policy relevant setting. So let me then move to motivating kind of why this might matter for sort of bigger policy questions. Sorry, I just want to make sure my timer is working, but as you fall asleep, I'll know that I'm getting to the end. So we want to think about, there's a big move towards, providing more incentives to more people. And the real question here, and I think this is fundamental to everyone in the room, right? In some sense, we're all here because we think the supply side matters. Right? We think that doctors using tools and with more information and better tools might change things. And if I went, I don't know if across the street or somewhere around here, someone I'm sure is saying that high deductible health plans are actually the panacea, right? It's just that people face low prices because they're insured, and that means they're using useless stuff all the time. And the answer is probably some of both, but I want to give you some motivating evidence for why understanding underlying heterogeneity actually matters for answering this question. And that is to say the average impact of a lot of policy questions or these different policies might really mask effects. And I bring that up first with the demand side question, right? The RAND health insurance experiment was the single biggest, most expensive anyway, it was also big, social science experiment in US history. To estimate the mean elasticity, they did other stuff, I don't want to belittle RAND, but the thing that everyone remembers, right, demand slopes down, -0.2, was to estimate the elasticity of demand for healthcare. Similarly, the Oregon health insurance experiment, very powerful causal inference in an RCT. We found out basically the mean effects on sick Medicaid enrollees who wanted insurance. Extremely important, extremely powerful. The question, of course, is, well, how do I interpret that, right? How do I turn that into a normative answer to, should I be relying on the demand side or the supply side? So it's not whether cost or quality change because of a policy, it's how. And I think that the tools that I'm talking about here, very quickly, might actually allow us to get even more into that black box in a much more flexible fashion, where typically as economists we've either cranked up a structural model to sort of, well, I assume that doctors do the following and therefore I can estimate all these parameters, or we've said, well, I have the late estimate, therefore that's what we should be making a decision based on. So let me just show you some data from a very large natural experiment that we've just completed. If you're interested, this will be coming out as an NBR working paper on Monday. We looked at a very large firm, 160,000 covered lives, who exogenously switched the entire company into a high deductible health plan. We see a long stream of data beforehand and then the change. And we look at a number of different features. Particularly, we're interested in the average utilization effect, but the heterogeneous utilization effect. We're also then able to use the microdata to actually understand price shopping versus quantity reductions. Right? So in this case, actually, it's an interesting setting. It's absolutely not representative. It's extremely highly skilled, extremely educated. They had been given full HR treatment. They had detailed price lookup tools. No, that's working. Maybe that's my sign. I still have 5 minutes. Detailed price lookup tools. And so we're interested in the question of, well, can they actually cut back in the fashion that we predict? And then lastly, they face these complex nonlinear contracts, right? And exactly the same way they did in RAND and they typically do in health insurance generally. And so we're going to say, well, what does Mr. Homo economicus do? He looks forward and says, well, if I'm pretty sick and I definitely am going to go past the deductible, my expected marginal price is 0, I should act like the marginal price is 0. But in actual fact, that may not be what's happening. So let me show you, this is the main effect, right? You see, this is the mean monthly spending. This is when the change occurs. Basically, just a very large and significant and continued reduction in spending. And that continues multiple years after, right? Which is somewhat distinct from earlier literature on this. You also see significant anticipatory demand, which you need to address, which we do in the paper. But then we start digging in, and again, this is not showing you the ML applications precisely, but more to motivate treatment effect heterogeneity here. Here we use the actual ACG scores, which is to predict spending flexibly off of the clinical data. So I can understand on a more nuanced clinical basis how likely you are to spend going forward, which is a measure of your severity. What I see is that the largest effect in levels, but it also turns out in percentages, is actually coming from the sickest people. Right? That's the first motivator for, well, if I just looked at this and stopped, I'd say, well, in equilibrium, everyone cuts back at the margin, so this must all be moral hazard. The optimal contract is actually much more risk exposure. But in actual fact, most of it's coming from the sickest people who, A, may have the highest returns in terms of health outcomes, B, actually face marginal prices, which should be low, right? If I'm very sick and I'm going to go through the deductible, then therefore my expected marginal price should be close to 0. Yet I may face spot prices over the year, so that's going to motivate the analysis. We can then look at price shopping, right? So this is maybe not a perfect, this is flipped over in some sense, but basically the total spending drop of 16.5%. If you look at the provider price changes, so providers aren't changing prices, we see absolutely no price shopping effect. That is within the same condition. So if we basically compare a doctor, if I afterwards wanted to get a colonoscopy at a different doctor, do I just not get that procedure, or do I move to a doctor that's lower price for a colonoscopy? Right? The classic sort of Dartmouth study, like how do we have all this variation even for homogeneous products? Well, people should be able to search based on price. We find no evidence. In fact, if anything, people are going to slightly higher priced doctors. So the entire effect is coming from those quantity reductions. And in the paper, we drill down and basically show that this effect is true both in preventive services where the doctor has actually diagnosed you already. So they've said, you have a condition that requires this preventive follow-up. You see no price shopping and large quantity reductions. It's also true of imaging services, which are basically completely homogeneous products. No evidence for price shopping, despite having detailed IT tools to do that. Right? So another set of motivators actually getting under the hood of this is saying, well, that mean reduction, maybe we shouldn't interpret that as moral hazard or excess spending, or certainly not people's behavior and their ability to cut back as a productive mechanism. Everything, the totality of it, yeah. So this is, and we break it, and I think this gets the exact idea, which is this is everything. But when you drill in, particularly for outpatient imaging, I think that's what you're getting to, is that you need to get under the hood in order to say it's efficient reduction, yeah. And then lastly, I'm going to go fairly quickly here, is we think about the dynamics of the nonlinear contract, right? And this is another area where basically using the detail of the data allows us to be predictive dynamically over the course of the year. And the fact that in the prior contract, they literally faced 0 prices ever allows a much, I think more defensible assumption, which is I can say that given everything I observe about an individual at period T, the entire flow of their healthcare consumption in the absence of prices would be the counterfactual for what would occur. Put differently, I can see basically how health transitions and utilization are manifest in spending. If you face no prices, then I'm going to use that as a counterfactual. So what you see here is, suppose, for example, I'm above the out-of-pocket maximum in July. That is, I've already spent so much that I faced no price, a price of zero. This yellow line is going to be 2011. That's when nobody faced any real prices. And this 2013 blue line is going to be after everyone's moved to the high deductible contract. They sit right on top of each other. So that is to say, if you actually face a spot price of zero, in both years you act exactly the same. So comforting on many levels. If you then look below the deductible, a large gap opens up. But importantly, you'll note that, well, you won't know because I'm not showing you here. This also holds even for very sick people with very high expected price at the end of the year, which begs the question, what are people responding to? Which is where we basically rely on a lasso to flexibly account for the fact that basically people face a whole host of prices, all of which are a function of spending, all of which are correlated with one another, and all of which, of course, are correlated with the outcome, which is spending, which would be potentially problematic if you were just to run an OLS. So instead, what we're able to do is basically run a lasso model where we can, as we crank up the penalty, what it's going to do is move these things towards zero, leaving the things that are most correlated with the outcome, even conditional basically on the correlations between the independent variables. And here you see, what we predicted in spades. This red line here is a spot price of 1. What does that mean? That's people under the deductible conditioning on all of the other data about them and their future prices. And this is basically showing you that, in fact, most of the effect is coming from people not based on their expected end-of-the-year marginal price, which is exactly what you would predict from a standard economic model, but based on how they respond to spot prices that they see the day of, which gives you a very different interpretation not only of how people behave and how they're making decisions, but also what an optimal insurance contract looks like, right? So I'm going to then jump. My supply side is getting cut out by technical difficulties. So I've just hopefully, I don't need to motivate you guys that the supply side matters. You're interested in IT. But what I'm trying to show is that we might have much more concern about relying on the demand side to ration care, which just further underscores the need to have detailed understanding of how people use IT and IT impacts utilization. I just want to have one more motivating feature, which, shameless self-citation here, but I think is a potentially fruitful area for much more detailed granular work, is to understand how information and information feedback impacts doctors, particularly independent of financial rewards. And so in some work that I did earlier and others have done, basically we find for bypass surgery, the vast majority of the impact of releasing information to the marketplace is informing surgeons who are intrinsically motivated. Right? It's not we're informing consumers to basically allow them to make better decisions. And that opens up a really interesting host of areas that I think, we should study in much more detail, potentially with experimentation within hospitals, within clinics, within firms, which is to give different types of information feedback to different actors in the healthcare system. And because we have the expansion of IT, because we have these settings, I am optimistic that we can do that. So let me then, jump to the end, which is just to tie things together and say, hopefully this motivated you that these tools are actually coming together with causal inference. And importantly, that they're actually really nice tools. So Susan Athey and Hito Imbens have a nice paper basically looking at this treatment effect heterogeneity, that this is actually, even if you don't want to do any of the other stuff, if you're really kind of, a labor person who's really focused on estimating that beta 1, no offense, no offense, no normative judgment on labor people, but this could be very powerful, particularly in a setting where we think there should be a lot of heterogeneity. We've seen a lot of evidence for heterogeneity, often with sort of ad hoc measures, clinical severity, et cetera, to flexibly understand how this heterogeneity impacts hospitals, impacts delivery as a function of IT is very exciting. And then combine those with basically academic researchers in the field constantly experimenting, I think will be a great avenue for future work. All right, thanks.
So thank you. Is this on? Okay. Thank you for the talk. That was very enlightening. I have a lot of interest in this idea, and And I think, the question that we often get is around like the theory contribution with some of these methods. Mm-hmm. When we're talking about kind of the beta 1, beta 2 context, we can specify like a pretty, reasonable theory and then test it, and then that's all kind of clear. In this case, I just want to make sure I'm understanding correctly. What you're saying is that when we think about prediction, we're saying is that with these methods, we think about what predicts better, and that informs theory? Is that kind of some of the takeaway, or just can you elaborate a little bit on that?
That's a great question, and I would say the answer to that is yes. I mean, it's somewhat interesting, and I'll say where I put my IO hat on is that these methods have been adopted often by people who were doing structural stuff in the first place, and so there was sort of a theory-driven empirics for various reasons. But actually, I think that's exactly what I'm saying, and I think that's an important feature here is that we've been I would argue somewhat constrained by I want to have a tractable model that tells me whether things should slope up or down, and then go test it in the data. I do think there's at least an opportunity in a lot of settings to transition to a more applied version. And I think if you look at sort of the top economics journals, more and more of the papers are applied empirical work where it's really understanding the totality of the setting. Motivated by economics, motivated by inference, but much less tied to that specific theory. But the flip of that is actually, I would say, an important motivator is to use this as hypothesis generating, right? Is to say, and I got a little bit at it where we have the standard model of demand sloping down, I lower the price or raise the price, you're going to cut back at the margin. Well, if we're not finding that behavior, can we have tractable behavioral theory or information in the model that can actually explain what's going on? So I would argue that kind of that's the one way to think about it. That's right.
Can you elaborate on one of I think it was your paper, you mentioned the incentives reducing mortality sorry, can you hear me?
Yeah.
From the hospital side, we are looking at different P4P models where, essentially it's working on the percentage. What percentage of physicians pay, take-home pay should be at risk. And in most cases, if you look nationwide, it's probably about 5%, although there are some models which go 15 to 30%. And IT has enabled us to get a lot of information and improve both process and quality measures. But if you can elaborate a little bit more on were those financial incentives, and can you directly say it reduced mortality? Was it just an association, or were there any confounders?
So the piece I was talking about was that basically it's looking at the change over time. So it's just a policy evaluation effectively as a function of these different features. So basically it's saying doctors that got more new information independent of their pecuniary rewards improved by dramatically more in that setting. It's not pay for performance. This is just information release, right? And recall that the theory underlying report card is well, there's information asymmetry, so we think people aren't going to allocate properly. If we inform them, the market will work. The argument and the results that I find there is basically that actually a much bigger effect, and it makes some sense if you sort of think about it, is that surgeons working in isolation, they know 0 is a good mortality rate, though frankly, if you're that good, you may not be actually working on, you should be working on more complex cases. The biggest effect seems to come from giving them information that had somebody else treated my patients, here's how well they would have done relative to me, and that's really shifting the needle much more than it is, allowing me as a consumer or a cardiologist to say, well, you don't want to go to Surgeon Kolstad, he's terrible. That has a small effect, a non-zero effect, but that's the pecuniary effect there. Now, I think the pay-for-performance area is very exciting. We're working on some new stuff using detailed clickstream data linked to the contract, and that's, I think, a motivator. But that's really one where you have this entire stream of physician behavior for years in response to a contract, and really, to make headway, you need these methods to just reduce the dimensionality of the data. But I think that's very fruitful, and to think about sort of the complementarities and also the heterogeneity. At least preliminarily, what we're finding there is that there's sort of price responsive docs and there's information responsive docs, and actually they're quite different. And that's going to lead you to very different and potentially much more powerful conclusions there.
This was fascinating. So I have two questions. One, are your slides available?
I can make them available.
Okay.
Yeah.
And the second was...
I'll look for typos first, but yes.
Following on Idris's point, it seems that what you're arguing is that data mining and some of the more advanced tools that are emerging are really grounded theory approach for economists. And that grounded theory for so long was mired as, we go in and we'd sit there and try and figure out the questions that we want to ask. And this is a more analytical way of trying to elucidate or observe those exact same original questions. Is that a fair way to think of your argument, or?
Yeah, I mean, I think it is, and I think that's something that I would argue has, somewhat constrict. We've said, well, profit maximization or some, sort of the Homo economicus model is where we start, and that allows us to get a really tractable view of the world, and we're going to go test where that doesn't occur. And I think that it's a reasonable way to say, well, let's ask, is it occurring in the way we would predict from those models, which is consistent, again, with some of the testing. But if it's not, I think it is a way to flexibly and at a much greater scale generate new hypotheses and ways to actually sort of understand that. Whereas before you said, well, it doesn't adhere to my model. I don't know if it's because, I'm not measuring it properly or because it's behavioral response. I think when you start getting under the hood, ideally it should not throw theory out the door. In fact, it should motivate, sort of push further. And I think you've seen that particularly with, like Johannes Spinowin. There's a number of people who are doing, sort of more junior folks doing behavioral theory linked to more applied settings. And this should really be a driver of that rather than replacing it. But the most important feature of that is because you have this, and I didn't dwell on this much, sort of the cross-validation approach, which is to say, I'm going to predict in this sample and go see how well it fits another left-out sample. That's the bread and butter of not overfitting, right? That's the constant concern of either sort of traditional data mining and economics, where I'm just going to throw in a bunch of X's and see which one comes out significant, or in the sort of more machine learning application of, well, there are idiosyncrasies in my data actually driving the predictions that are not going to be real in practice. Done properly, and there's a lot of thought on that, actually, that's going to mitigate that problem. So I think we as economists should be doing more cross-validation anyway, right? We shouldn't be comfortable. We've typically, I think, to that point, been comfortable, well, my R squared is 1%, but beta is really precisely estimated, QED. And we should not be as comfortable with that. We should be trying to explain more of the variation. I mean, in the extreme, then you have to rely much less on IV, right? If the error term gets small enough, and I don't want to go that far there, but that means that you have a flexible and a empirically and mathematically grounded approach to say, I'm going to look for this heterogeneity without saying, well, you just looked under this rock and found it. Why should I write a theory about it? So I don't know if that's exactly getting to the question, but I think it's potential.